February 23rd and 24th, just no class.
Yeah, because I'm in Texas at a conference that week.
Okay.
Yeah. And then there's a Monday in there too, the 16th, I think it is.
Later,
Yeah. Okay. From current. Okay, so just to bring you back up to speed with where we were, the pancreas sits. Okay, so this little part here, this is the first part of the small intestine called the duodenum or duodenum. Which here's the stomach, right? Here's the esophagus. Here's the duodenum. I call it duodenum, but some people call it duodenum. And the pancreas sits here in that little crook of that little arc from the first part of the small intestine. And we'll learn all about this anatomy in the digestive tract, but it basically is a large kind of tadpole-shaped gland, right? It has a head, a body, and then a tail at the end. Running through the middle is a long duct. Into that duct flows those digestive enzymes that the pancreas makes. Our concern in this chapter is the little islands or islets of cells that come between those digestive systems. So these are secreting digestive system enzymes. But this little bundle of cells secretes glucagon, insulin, growth hormone, inhibiting hormone, and this pancreatic polypeptide. Now, the only two that we're going to talk about in here are the bolded ones. So glucagon and insulin are what we're going to talk about next. And then growth hormone inhibiting factor is the very same substance that the hypothalamus produces as part of the growth hormone control system. So it's a second source of that. All right. So blood glucose, of course, you've all heard of glucose. Many of you will have heard of blood glucose, too, because of a very, very common and set of diseases called diabetes mellitus, which when we're done with this, I'm going to give you a little clinical side of the endocrine system, and we'll look at why that disease is so bad. But before we can look at that, we need to see how is blood glucose levels, how are they regulated in the body? And first you may say, well, why do they have to be? Well, the brain can only metabolize glucose. Nerve cells are the most finicky cells of the body because they're so specialized for sending signals very rapidly and for producing neurotransmitters rapidly that they just don't have very much metabolic capability. So you can think of it as, if the cars that we drive around every day, they're like regular cells, right? They can take different kinds of gasoline, they can take different kinds of oil and all that. Whereas the brain cells are sort of like top fuel dragsters. They have to have their special fuel in order to work. Another example is like the hummingbird. Because its metabolism is so high, it basically has to eat sugar all day long because that's the only thing that has enough energy and can be digested fast enough. So the brain cells are like that. So we have to have enough glucose around all the time for the brain. Even in between meals when there's no glucose coming in from the digestive tract. So we have to have some. Well, why do we care if it's too high? Too high of a glucose level starts to affect the small arteries in particular. It causes them to clog, and it causes blood flow through them to be rather poor. Plus, high glucose levels also cause water to leave the body in the kidneys as the water follows the sugar that goes into the kidneys and then out. So it can lead to dehydration. So typically speaking, in normal healthy people, the glucose range in the blood is from about 70 to 110. Ideally, you want to have a glucose between 80 and 100 is what most endocrinologists would say. But your book says 70 to 110. So why would it change? Well, the biggest thing that changes in terms of blood glucose is what's going through the digestive tract. Pasta, for example, is mostly starch. Starch in the digestive tract is broken down into sugar, particularly simple sugars like glucose. So when you eat a meal that's high in carbohydrates like that, suddenly there's huge amounts of glucose coming in through the digestive tract. That would have a tendency to push blood glucose levels up if there wasn't some control system to prevent that. In the inverse, in between meals, or if you've had a high protein, high fat, low carbohydrate meal, your blood glucose level starts to fall, and the brain, needing glucose, can't handle that. So there has to be a bottom end and a top end. All right, so we'll look at rising levels first. So you've had that big pasta meal, and an hour later, your blood glucose level is starting to rise because all that starch is being digested. Well, the response of the body to that is the beta cells in the pancreas sense that increase in glucose, and they release insulin. And insulin does all sorts of important things. All right, so one is insulin controls how rapidly glucose enters all the cells of the body, except brain cells. Brain cells, glucose can always get into brain cells because that's the need, remember? But all the other cells of the body can either take in glucose or block glucose from entering. So insulin, one of its roles is it is the key that opens the door that allows glucose into cells. Okay, so when those doors open, glucose flows into the cells. The cells use glucose preferentially as a fuel because it's very efficient for cells to use that, and that causes the blood sugar to go down. Makes sense. If the sugar in the blood is going into the cells and being burned into carbon dioxide and energy, well, that blood sugar level is going to fall. So that's one way insulin reduces blood sugar levels. Another way is inside of cells, insulin triggers the use of glucose over other fuels. So in our metabolism chapter after spring break, we're going to talk about how the body can use proteins, lipids, or fats as fuel, right? Or I'm sorry, carbohydrates, lipids, and fats. Carbohydrates, lipids, and fats. No, carbohydrates, lipids, and proteins. I'll get it eventually. There's three of them. Anyway, insulin shifts the metabolism towards carbohydrates. Burn carbohydrates like glucose. When insulin is not present, cells drift back towards burning fat or burning protein as needed. So that's another way. First, we get the sugar into the cells. Then we tell the cells to burn that sugar to use as fuel. Both of those are going to reduce blood sugar levels. All right. Another is insulin triggers the storage of glucose. So glucose can be stored in these great big molecules called glycogen. Glycogen is a starch. A starch is a long chain of sugars. All right. So to give you a little visual to go with that, you know, you've probably learned in chemistry that glucose can be represented like that, right? It's a 6-carbon ring. Well, I'm going to make that a circle for the use of drawing. So if that's glucose, glycogen looks like this. Lots of glucose molecules all stuck together in these branching chains. Okay, so this is glycogen. There can be hundreds of thousands of glucose molecules in a single molecule of glycogen. So if we trigger this direction, our blood glucose level is going to go down because the glucose is being frozen, so to speak. It's being locked up into these glycogen molecules. That takes it out of the blood. That makes blood sugar levels go down. Okay, so glycogen is our human starch. Plants make different kinds of starches. Animals make different kinds of starches. But in the end, a starch is a chain of simple sugars like this. Much more on that in our metabolism chapter when we get there. Okay, so that's this piece. Store glucose as glycogen, get it out of the blood, causes blood glucose levels to fall. And then these last two are not directly related to blood sugar, but they're added benefits. So insulin causes an increase in amino acid synthesis and an increase in protein synthesis. How is that connected? If there's lots of blood glucose around, chances are there are lots of other nutrients coming in through the digestive tract too. That means it's a good time to build and repair stuff, right? If you've got a big meal, lots of nutrients coming in, well, you might as well use those nutrients to repair cells, replace amino acids, and that kind of thing. So it's a building up time, you know, so cells get to repair and maintain and replace parts that are worn out. And then the last one is insulin causes triglycerides to be synthesized in adipose tissue. In other words, insulin triggers the production of fat in fat cells. Again, it's because if glucose levels are high, causing insulin to be present, that means there's lots of nutrients, might as well store it up for a rainy day as adipose tissue, right? So all of those, well, the top three things, cause a decrease in blood glucose levels. The bottom two things don't directly do that, but it's good things to do anyway. So because of those top three things, the blood glucose level goes down. Remember, that's what triggered this, is blood glucose levels going up. And we get back to homeostasis. So this is the insulin loop. And this is the loop that gets deranged in diabetes because there either is no insulin production, that's type 1, or the insulin production is not adequate for all the cells in the body, that's type 2. And instead of reducing blood sugars, the blood sugars just keep getting higher and higher. And we'll talk about what happens because of that in a minute. Okay, so this is the insulin side. The other side, which I'm going to call the glucagon side, well, what happens if glucose levels get too low, which does happen? So you've got insulin pumping out. These top three things are happening. Glucose is going into cells, getting burned, getting stored. Well, what happens when that meal is used up? Now you're 6 hours or 8 hours after that meal. All the nutrients have come in. You're sound asleep, and your blood glucose levels start to fall. Well, the first thing that happens is insulin secretion turns down, right? So we turn off these top three things. But then also glucagon is released. And glucagon causes the opposite reaction. So glycogen is broken down into glucose. So we'll call this one insulin. Remember, that's just one of the things it does. We'll call this one glucagon. Right? So if this is broken down into simple sugars, that causes the blood glucose level to go up, right? We're unfreezing that glucose and putting it out into the blood. So that's this top one. The liver almost always has a storeroom of glycogen for a rainy day. Now, it isn't infinite. If you were to go without carbohydrates for several days, that's when your glycogen stores start to diminish and the liver has to do other things to start producing glucose. If you've heard of the Atkins diet or the low carbohydrate diet, that's one of the tricks that gets people to lose weight, is you use up all the glycogen and then the liver has to turn other things into glucose for the brain. And one of those things that it turns into glucose is fat. So it's one of the reasons for that. We'll talk a little bit more about diets when we get to that metabolism thing. But that's this top one. Break down glycogen. Another is break down fat. So when glucagon is present, fat storage is used for energy. So instead of storing fat, the fatty acids are released from adipose tissue, circulate around the body, and are used by all the cells except for the brain, because they don't know how to use fatty acids. But muscle cells do, epithelial cells do, bone cells do, all the other ones do. All right, so we get that one. And then glucagon also causes the liver to produce glucose from other things. So again, lots more on this later. But the liver is a totally cool metabolic machine. It can do all kinds of chemistry that we have yet to figure out how to do in the lab. And one of those things that it does is protein, lipid, and lipid can be funneled into the liver, and it does magic, right? And then out the other end comes glucose from the brain. So even if you don't have any carbohydrate in your diet, and all you take in is protein and lipid, like our carnivore friends, right? Like our dogs and cats in the wild, and other, carnivore mammals like lions and tigers, they don't get much carbohydrate. Their diet is meat, right? And meat is protein and lipid. Well, their brains need glucose too, but they have similar liver that we do, so magic happens. And these things can become glucose to keep the brain alive. Also, that's another way to look at that low carbohydrate or Atkins diet. It's the carnivore diet. It flips our metabolism instead of being omnivores like we are. It flips us into a carnivore metabolism. And for a lot of people, it causes pretty stable weight loss. The only downside is you have to give up carbohydrates, and when you ever go off of it, you have a tendency to gain the weight back, like so many other diets. Okay. So blood glucose levels increase. Well, which of those three things do that? this one, and this one, so the top and bottom one, actually cause blood glucose levels to increase. If we're making glucose, that's going to increase blood glucose levels, right? And if we're breaking glycogen down into glucose, that will too. So glucagon increases blood glucose levels. Now, in some diabetics, particularly type 1 diabetes, in other words, they don't produce insulin at all, they always have a risk of low blood sugar because they take insulin, you know, they inject it usually, or it's injected by a pump. And if they don't eat enough carbohydrates to match the insulin that they've taken, their blood glucose level can start to fall. They can get kind of disoriented, and they can even have seizures, coma, or they can even die. So all that to say that many type 1 diabetics carry a glucagon pen. You know, you've heard of an EpiPen, if any of you heard of that. You know, super allergic people will carry them. It's an auto injector, so you just stab it into somebody. You have to stab them really hard because it's a tight spring. But that saves them from dying, right? Well, diabetics often will carry a pen with glucagon in it. So if they start to feel that hypoglycemia and they can't get access to something with carbohydrates in it, it will at least keep them functioning long enough to get food, basically. So many diabetics will carry a glucagon pen. So you'll hear about glucagon in that sense. So just like we saw with calcium, that we have a hormone that handles the too high and a hormone that handles the too low case, same thing here. Insulin handles the too high case. Glucagon handles the too low case. But they're both active in blood glucose management. All right. Okay, so we did all that already. And okay, so we'll do some questions. Some of these are from last time. My lectures aren't quite fitting into our time, but it'll be okay. All right, so all of the following result from thyroid hormone, except, so this is one of those except questions. Find the one that isn't true. Oh, I have to send the question. Sorry, my bad. There we go. Now it's coming.
So if you already don't eat, like if you barely have if you have lower ingested protein, it can really, and you also don't have enough sugar or glucose, the protein that you do have is being used to turn into glucose.
Yes.
So then that's why you can't put on muscle.
Correct.
Dang it.
Yeah, it doesn't work like that. You can't tell the protein where to go. So yeah, the protein will only get used for muscle if there's enough nutrients for everything else. Otherwise, you can actually get into the reverse. If you don't have enough, protein is a lousy source of energy. But if you don't have enough fat or carbohydrate in your diet, in other words, you're like a protein junkie, but no lipids, no carbohydrates, the body's only choice then is to break that protein down. And it's non-selective. It won't just break down the protein you're taking in, it will break down protein that's hard in your muscle too.
So that's why bodybuilders have to have insane calorie amounts every day.
Yes, and muscle burns calories just sitting there, even if it's not being used. So yeah, these great big, they have huge calorie needs. But it isn't just mass; it's also efficiency. So your marathoners, your ultra marathoners, they have big calorie needs too. 3,000, 4,000 calories a day, or even more. Some of the real in shape professional athletes, they probably knock down 5,000 or 6,000 calories a day to maintain all that muscle mass. Okay, so best answer there. Let's see, what did you guys put? Split between B and E, but B was most common. B is correct, right? So thyroid hormone causes an increase in heart rate and contraction, not a decrease. So this would be the absence of thyroid hormone. But the rest of those, yes, elevated oxygen consumption, increased sympathetic activity, normal sensitivity for respiratory center, and then red blood cell formation. Gotta have it. Okay, the C cells of the thyroid gland produce which of those? Hormones. Who's had biochemistry? Did you learn any of the magic? Yeah? Okay. That magic right there is biochem, which I was really bad at. So I just think of it as magic now. And that circuit is fine. All right, 10 seconds. Get in there if you haven't. Good. Socrative seems to be working pretty good. Anybody having connection problems or it's dropping you out or anything?
I can't forget my answers.
It won't let you ever?
No, I've tried for the past 2 and it's not letting me.
I don't think it's Socrative though. I didn't see it or not.
Yeah, well, it's never Socrative. It's always the network. That's why I'm asking. Yeah, they told me that we may run out of connection slots in here, but we'll play later. Okay. C cells go with C calcitonin, so they match. So calcitonin comes from C cells. Its partner in crime is parathyroid hormone. So calcitonin brings calcium levels down. Parathyroid hormone increases calcium levels in the blood. Remember we talked about how it goes to the bones and the kidney and all that last time. And here's one that should sound fresh. When blood glucose levels fall, which of those things happens? Okay, so again, we got a split between B and E. When glucose levels fall, glucagon is released. So glucagon has glucose in its name, right? Glucagon makes glucose, if you can think about that. So glucagon makes glucose happen. So when blood glucose levels go down, glucagon is released and it causes glucose levels to go back up because it triggers the production of glucose by release from glycogen or production, like you see over there. All those other ones are when the blood sugar levels go up. So insulin is released when blood sugar is too high. Peripheral cells take up more glucose. Remember, the door is open. Protein synthesis goes up because there's plenty of energy and nutrients around. And glucagon is released. Yeah, E is not correct because protein synthesis goes down. Like I was just talking about with D. Okay. Okay, brief, and then we're going to get to an interesting topic. Pineal gland is located here, at just above the cerebellum. It's one way to think of it is it's another center of the brain. You know, if you were to throw a dart at the center of this picture, you'd hit the pineal gland. And the pineal gland is one of the few structures in the brain that there's only one of. Everything in the brain has a right and a left that are symmetric. Well, the pineal gland doesn't. It just hangs out there. It's one little gland. There was a time long before we understood how the brain worked that people thought that the pineal gland must be where the soul is because it's the only part of the brain that there isn't a left and a right for. So the only singular structure in the brain is the pineal gland. And of course, you only have one soul, right? So it must live here. But we don't think that anymore. Now we know the pineal gland produces melatonin. And like I talked about the other day, what does melatonin do? We know this one. We know that it helps to establish rhythms, particularly the sleep-wake rhythm, because melatonin is produced in greater amounts when less light is entering the eyes. So the darker it gets, the more melatonin gets released. It plays some role in controlling reproductive function in terms of the long cycles of it. And melatonin is a great antioxidant. So its existence in the body also helps to protect us from free radical damage that we get from certain molecules in food we eat, in toxins in the air, toxins in the water, those kinds of things. So melatonin, pineal gland, that's about it on that. Okay, so this is very famous, and it's in the news all the time. So I spent a little time talking about diabetes. All right. Diabetes by name means sugar urine is what diabetes mellitus means. And it's because when blood sugars get too high, greater than 300 in most people, then glucose starts spilling into the urine, and it makes the urine have sugar in it. And again, long before there were fancy devices that we could study urine with, one of the ways of diagnosing diabetes mellitus is the physician would taste the urine. And if the urine was sweet, then it was diabetes mellitus. If it had very little flavor at all, then it was another diabetes called diabetes insipidus. So aren't you glad you live in the modern day when you're not going to have to perform that test on your patients, right? Now we just use a little fancy stick that changes color depending on what the blood glucose level is. So that's what that name means. It's sugar in the urine. But diabetes mellitus at its heart is a blood sugar control problem. In other words, there is either not enough insulin produced, or the insulin that is produced is not adequate to keep blood sugars in that 70 to 110 range. Now, there are two types that are very different, even though they share the same common outcome of too high of blood sugar. Type 1 diabetes is a pancreas failure. Basically, the pancreas fails to produce insulin, usually insulin, not any insulin at all. And this is the diabetes that typically affects children, because the onset of type 1 diabetes is usually between age 3 and age 10. Okay, so it usually starts in childhood. Tons of research going on about why does type 1 diabetes happen. We still don't know. There's some evidence that it's an autoimmune disorder. In other words, that the immune system destroys the pancreatic islets and therefore the insulin-producing cells. There's some evidence that connects it as to viral illnesses. In other words, you get a viral illness, and because of your unique immune system, your body accidentally destroys the insulin-producing cells too. But the bottom line is we don't know. Of the two, type 1 is usually the most difficult to manage because there is no such thing as an insulin pill, right? Insulin is a peptide and would be totally destroyed by the stomach. So the only way to give insulin directly is by injection, which means your type 1 diabetics are injecting something under the skin all the time. Now, insulin doesn't have to be put in a vein, thankfully, but it does have to be put under the skin for absorption by the blood vessels. Now, in today's world, there's a big movement to moving to insulin pumps instead. So, people will wear a little pager-looking thing that has a tube that runs into their under their clothing, and at the end of it, there's a little needle under the skin that's taped out, and a little bit of insulin is put in there all the time. So the goal of managing diabetes mellitus is to keep blood sugars in the normal range. Now that has changed in the last 15 years. It used to be it was to keep blood glucose levels below 200. Now we know it's better to keep them in the normal range. So the goal for both types is blood sugars of 70 to 110, ideally 80 to 100. Okay, so if there's type 1, well, what is type 2? In the type 2 diabetic, their pancreas produces insulin, but it doesn't produce enough to keep blood sugars in that range. Okay, so why? Well, it's either the pancreas is a bit lazy, which is not the usual case, or because of the patient's body mass, the pancreas can't keep up with all of the cells, right? So the more adipose tissue you have, the more cells you have, okay? It's not that the cells you have get bigger, you get more cells. More cells mean more insulin or glucose stores, and so the insulin produced by the pancreas can't keep up with all those cells that exist. So you get this mismatch. So the glucose levels stay higher than normal, even though insulin is being produced. Now, the type 2 diabetic has some options because there are some medications that trick the pancreas into producing even more insulin than it normally does, or can affect glucose levels in other ways. So type 2 diabetics can usually be managed without insulin injection. They take other medicines, which you hear about them on TV sometimes. You know, a very famous one is called metformin that helps to lower blood glucose levels by stimulating the pancreas to basically produce as much insulin as it can. Okay, so when is this a problem? You know, blood sugar or insulin deficit, type 1 or type 2, that all by itself isn't the problem. The problem in diabetes is when blood sugars are too high for too long. If we control blood sugar to keep it in the normal range, there are no problems with diabetes. You can live with diabetes, live a normal, healthy life, not have any problems at all. So we know that it isn't the insulin problem, it's the glucose. So, in short, diabetes mellitus with uncontrolled high glucose, in other words, your glucose levels are above 200 all the time, or way more often than they should be, causes directly problems with small arteries. Okay, so I learned a while ago in medical school, we think of diabetes as a blood sugar disease, but uncontrolled high blood sugar is a small artery disease. Okay, and I'll explain why this is such an important point here in a minute. Because this part here, small artery disease from high glucose levels, causes all of the problems for diabetes. Okay, one cause, small artery problems, causes all these different things. Okay, so what are some of those things? Why do we care? Why do we spend so much time treating patients with diabetes? Okay, first, in the eye, the retina is supplied by small arteries. So high blood sugars over a long time damages those small arteries. The result is what is called diabetic retinopathy. Diabetes, uncontrolled, is the leading cause of preventable blindness in the world, certainly in the United States, right? So that's point number one. High glucose, small arteries, retina dies, blindness ensues. Okay, so that's one reason we treat diabetes. The second is cardiovascular system. So the heart is supplied by small arteries too. Not the coronary arteries, those are medium-sized arteries. But the branches of the coronary arteries are small arteries again. So one of the most significant risk factors for heart attack and heart disease is uncontrolled high glucose levels, right? So there's another big one. There's another killer. This one doesn't kill you, it just makes your life much worse. This one's going to kill you, okay? Then we get to the kidney. The kidney works because of small arteries. So high glucose, small arteries, the kidney starts to fail. The leading cause of preventable kidney failure in the United States is diabetes mellitus type 2. So we call that diabetic nephropathy. Basically, the kidneys slowly die. Most patients who are on dialysis are type 2 diabetics, uncontrolled high blood glucose. So why don't we just slap in a new kidney? Because unless they have their diabetes under control, they'll destroy the transplant too. So until you can prove that the patient's in good control and is going to stay that way, they're ranked very low on the kidney list. Because essentially, they didn't manage their disease, and that's why they need a kidney. They weren't born with some problem. Yeah.
How long can you live with that diabetic?
With diabetic nephropathy, depends on how well you control your blood sugar. and it depends on how far gone the kidneys are. You can technically live forever on dialysis, but it's not a very good life. You're talking about spending 20 hours a week having dialysis, so you don't have much of a life outside of that. Because then that's just sitting there having the dialysis, and then you feel like crap for the next 6 hours. So by the end of the week, you've had about 10 good hours. You were first, yeah.
So let's say like a type 1 diabetic, and they get mostly within that range, but every once in a while
they're out
without taking insulin, and they'll go up to 200 or 300. Does that also increase by a lot, or like how much? Like how irregular does it have to be to get those diseases?
It's kind of an area under the curve thing.
Yeah.
In other words, you want to have most of your time between that 70 and 110.
Yeah.
The more time you have above that, the higher the risk for these things, and the faster they progress. So, yes, if you had a bad day, you missed this insulin shot, or you didn't eat what you were supposed to and you spiked, that's not going to matter. It's, do you do that regularly enough to have a significant amount of time with high blood glucose levels? And we have a test for that. It's called the hemoglobin A1C, and it tells us how often are your blood sugars high. Yeah. All of these things are related to hemoglobin A1C. As it goes up, these risks for these go up.
So why do diabetics not have to take care of their skin really well, or can't bleed that much?
We're getting to that. Yeah, hold on, and you'll see in a minute. All right, so that's the kidney, leading cause of kidney-related death. All right, so nerves is the next one. Nerves need blood too, because they're high-energy things, right? And nerves are supplied by small arteries. So uncontrolled high blood glucose, the arteries that feed the nerves are damaged. The nerves are then damaged. And people with uncontrolled type 2 and type 1 diabetes, they end up with neuropathy. Neuropathy starts with numbness and tingling. It ends with numbness and paralysis, right? So one of the leading causes of loss of sensation, particularly, it usually is below the knee, is from what is called diabetic neuropathy. And like you were talking about, if you can't feel your skin, you don't know if there's damage to that skin. So what happens in these patients, they can't feel their feet, or they can't feel anything below their knees. And, in the course of life, our feet are damaged from time to time, right? We step on stuff, whatever. Well, they don't know that. They don't know their feet have been damaged. So, and then it gets infected. That doesn't hurt either, because they don't have any feeling, right? So then that infection gets rampant. It becomes necrotic, and tissue dies. They get gangrene. So the leading cause of amputations below the knee in the United States are from diabetes type 2 uncontrolled. So it's from the neuropathy together with this next thing. The distal portions of the body, the hands and feet, are also supplied by small arteries. So now, while you can't feel your feet, the blood flow to your feet is really crappy, right? So the less good the blood flow, the higher the risk for infection, the higher the severity of infection. So the reason why many diabetics are missing feet or even legs below the knee or even higher is these two things together cause infection, and infection that can't be cleared because the blood flow is so bad. So the lower the blood flow to a region, not only does it not fight off infection, but it's hard to cure infection. You give somebody a powerful antibiotic, you think, oh, this is going to do it. Well, without the blood flow, it's not. The bacteria are going to win. So basically they get massive infection, wounds that don't heal, and eventually, it's sad, but these patients, they end up losing a toe, then they end up losing a foot, and then it's at the ankle, and then it's below the knee, then it works its way up. Yeah.
How does being an alcoholic affect being diabetic?
Usually it has to do with it's nutrition related typically, because typically alcoholics have very poor nutrition, which makes them a higher risk for diabetes. And if they have diabetes and have poor nutrition, then they're at triple risk. So that's the connection there. Yeah.
Once you have small artery disease, can you, if you get your diabetes under control, can it reverse it?
It is not reversible, but halting the progress can look like reversal. So for example, like in the kidney, you're never going to grow those nephrons that are dead back. But if you get your blood glucose in control again, kidney function recovers a bit. So you do get a little bit because it's not dying anymore, it's getting better, but you never grow these things back. Retina is like that, nerves are like that because nerves don't grow back. The blood flow to the limbs can improve over time. But yeah, yes.
What about like abscess? Like what is
It's the same thing. It's low blood flow and lack of feeling means that the bacteria win because the patient doesn't know they have a problem there, so they don't do anything about it, and then it eats the foot. Yeah. Some of you will take care of wounds in patients, and some of the nastiest wounds you'll ever see are because of these bottom two things. We call them diabetic feet. They have a name. So the diabetic foot, it's because it's usually necrotic, gangrenous. For those of you who know some microbiology, anaerobes play a major role, so it's stinky, nasty stuff. Yeah. There are even special clinics just for the diabetic feet. Yeah.
Question: why can't any diabetic woman have an actual birth? And it's mostly C-section.
Usually that's because the babies are big.
Oh.
Yeah, because moms who have diabetes, what happens is their blood sugar is high.
Mm-hmm.
So that means the baby's blood sugar is high too. So they pack on the pounds because the babies, their pancreas does work. So they're secreting insulin, and remember, insulin causes fat to be laid down. So they're these 15, 20-pound babies. That's usually she can have a C-section,
Yeah.
but only if the baby's small enough. So the reason that oftentimes they don't is because, well, it's two things. One is the size of the baby. The other is, baby is being born, you clamp the cord. When you clamp that cord, you're shutting off mom's high blood glucose level. Baby has never had to make a dime of glucose ever because it lived in this high glucose environment. So the baby's blood sugar can drop, and then you have seizures, coma, and maybe death. But I've been a part of multiple natural births with infants. We call them IDMs, infants of diabetic mothers.
So you just have to, like the mother.
Where they come out, we put an IV in them with sugar
Oh wow.
to keep their blood sugar up,
Wow.
and we have to wean them off the sugar and the insulin over time. They usually turn out fine, but they're the big fat babies that you see. Or like National Enquirer, 16-year-old gave birth to 30-pound baby. That's a diabetic mother.
Oh, wow.
That's the way we get that.
So that's not the same for gestational diabetes then, right?
Gestational diabetes is some women, when they're pregnant, have higher than normal blood sugars. Usually that's a sign that their blood sugar system is not perfect. Because if you had gestational diabetes, your risk for type 2 when you get older is much, much higher.
Mm-hmm.
So it's a woman that we would really encourage to watch her weight and exercise and try to stay out of that obese window where you start to get that.
But the health risks for the child isn't the same as.
It's not the same thing because you're not talking about super high blood sugars.
Okay.
Yeah. Yeah, you had one.
Yeah. I have a question. So for like the clinical problems, is it kind of like step by step or hit and miss for what they get? Because I have an aunt who has diabetes and she's legally blind now.
Mm-hmm.
So, but she's never had heart attacks or kidney stuff.
It does depend on the person. Not everybody will get all of these things.
Okay.
The two that almost everybody get are these, well, three. The retinopathy, the nephropathy, and the neuropathy.
Okay.
Yeah.
So it just depends on the person.
Yes, depends on the person. And with blindness, there's been small vessel problems. So there's probably kidney damage. We have more kidney than we need, so it doesn't show up right away. But it is a reason to get control of the blood glucose. Yeah.
Sorry, really quick. Is there a problem? Is there something to do with diabetes where the cells or tissues don't recognize insulin? Is that part of type 2, or is that?
It is part. It's called insulin resistance, and it's not that the cells don't recognize the insulin. It's usually that there's too many cells for the amount of insulin that the pancreas can produce.
Okay.
Yeah. But there are lots of variants, and that is one where the cells need more insulin than they should.
For some reason,
And it's
it's
probably because they've been in this high glucose environment for so long that they've adapted to high insulin levels. Just like you see in opiates, you have to have more of the drug to have the same effect. You'd see that same thing with high insulin levels over time because it's called upregulation. Yeah, good. See, interesting topic, huh? So, endocrine for sure because it's an insulin problem. But the take-home message is small artery disease, right? Remember, going into your future, diabetes is a vascular disorder, even though it starts with a metabolism disorder, an insulin problem. All right. Okay, real briefly, and then we'll call it a day. We'll probably finish this up next time. Okay. So we've talked about hormones in isolation. This hormone does this hormone does this, yada yada. Well, most cells of the body have receptors for more than one kind of hormone. So that means that different hormones can interact in the same cell. So you can have antagonistic effects. In other words, one hormone turns the cell up, another hormone turns the cell down. So where does it end up? Either neutral or a little bit higher or a little bit lower. So you have antagonism. You have addition. So 1 and 2 together can cause a dramatic increase. This is what we see with thyroid hormone and the sympathetic nervous system. When we have thyroid hormone and epi or norepi present at the same time, we get a much greater effect than if we have only one of those. So they can add together. You can have a kind of gatekeeper effect where hormone 2 doesn't do anything until hormone 1 is already present and active. Okay, so we have that. And then we have what the book calls integrative effects. In other words, they do different things. So hormone 1 does one thing in the cell, hormone 2 does something else, and they may not have anything to do with each other, but the cell is affected by both, right? So it wasn't doing A, B, or C. Now it's doing A and B, and C is still not doing. So it's different messages causing different effects in the same cell. So just basic interaction stuff. Okay. Let's stop there. I'm actually not going to cover this one in this chapter because we're going to hit this in the cardiovascular system in the next unit. Okay, so next time we'll start, we'll do growth and then the stress response because those are really important. And then we'll start in on the blood, right? Good questions today about diabetes. I like that.